So I thought I should speak on a topic which will benefit all. So I've taken now that certain common clinical problems that we all face and to which we don't find answers in our regular textbooks. Common day-to-day problems, because the textbooks or our all literature that focuses on a generalized situation, how to treat infarct, how to treat acute coronary syndrome, how to treat hypertension. But when a particular patient comes with complications, with comorbid conditions in a day-to-day life, then it sometimes is difficult what to do in a particular patient. So I'd like to go to the common problems. Now this is a question many doctors especially used to ask me. In fact, I would have liked a response system here, but it's not there. A 45-year-old male doctor, non-smoker, with a blood pressure of 140/90, total serum cholesterol of 200, HDL of 45, and he wants to know whether he should take aspirin prophylaxis regularly. This is a very common question which is asked to me by many of the doctors. Should I take as a prevention aspirin so that I don't have infarct or CV in future? Now, what is this? This is especially a situation of primary prevention. Primary prevention means the persons who have not had any cardiovascular event prior, either angina or infarction or positive stress test, and if they want to know whether they should take aspirin to prevent an event in future. So this is, now let's look at the different trials which have been conducted for primary prevention with aspirin. Now these are the different trials. You will see WHS trial, HOT trial. I don't know whether it is visible from there, but it's not visible from there. If the lights can be dimmed here, it will be easier. Okay. Now these are the different trials. These are the different trials, and these trials dealt with a different population group. Now some dealt with only healthy women, some dealt with men, women with hypertension, some with some risk factors for coronary artery disease. Now this is a physician's health study, but it was a very large study done in US. They dealt with doctors only, all healthy male doctors. They took aspirin. Then this was a British doctor study. So only doctors, they took aspirin, and they found whether the projector is off. Yep. And this is a study which looked with men with different risk factors like hyperlipidemia, smoking and all. So these are the different populations which looked at the effect of aspirin as a primary preventive measure. Now this is graphically depiction of the same different trials. Now this is very important. These are the results with all these studies. You will see different population. The women health study was a 39,000, very large trial. Physicians health study, very large, 22,000. When you come to the results, you will see only one study. This is a physician health study which showed the p-value is less than 0.001. So all the trials except one trial showed that taking aspirin is useful. And if you combine the results of all, then you will see the p-value is 0.00. So aspirin is not useful in all patients as a primary prevention. Then whom should we give aspirin? Now it was mentioned that diabetes is a coronary equivalent. I mean, having a diabetes is like as good as having a heart attack. So all diabetics patients should take aspirin. This was believed till recently, and the prescriptions of all the diabetologists carried aspirin in them. But when the meta-analysis was published, this was published in 2 years ago in Lancet, it showed all the trials, large number of trials, some 20-25 trials of aspirin versus placebo in all diabetic patients. And what was the result? See, for major cardiovascular event, this is a total, non-significant. For myocardial infarction, non-significant. For stroke prevention, non-significant. Death from cardiovascular causes, non-significant. All-cause mortality, not significant. So aspirin as a primary prevention in diabetic patient should not be a part of the prescription. Not all diabetics should receive aspirin. Now, who are the ones then should receive aspirin? Basically, the problem of aspirin is, as you know, the aspirin patients are prone for bleeding. And this risk of bleeding is constant. That is 2 per 1,000. That's the risk of bleeding. The benefit varies. The benefit of aspirin varies according to your pre-existing risk. Whether you are pre-existent risk for having a coronary event, whether you are a diabetic, smoker, hyperlipidemic, whether you had a stroke. So what is your baseline risk? That will confer the benefit of aspirin. More the baseline risk, more the benefit of aspirin. If the baseline risk is low, then your risk of bleeding outweighs your risk of benefit. So naturally, it's not going to be useful. So it is very important that you have to know what is your baseline risk. Otherwise, the risk of bleeding is same in all. That is 2 per 1,000. Now, this is an interesting table. This table shows you about a meta-analysis. Aspirin does what? Beneficially and harm-wise. If you treat 10,000 patients with aspirin for 10 years, hypothetically, if you are going to treat 10,000 patients with aspirin for 10 years, what is going to happen? How many deaths is it going to prevent? It is going to prevent some 39.5 deaths. It is going to prevent death, MI or stroke, some around 72. Total events 55. Cancer-related, colonic cancer-related death, it is going to prevent 51, all cancer deaths, and colorectal cancer 35. So if you add all this, the figure comes to somewhere around 225. So the total benefit is maybe of 10,000 patients will be in some 225 odd patients. Then what is the harm-wise? If you go to harm-wise, major bleeds are going to be 47, GI bleeds are around 150, and this 9. So when the harm is around 200, so 10,000 patients, 225 you are going to benefit, 200 are going to be harmed. So roughly it is balanced out. So still a final verdict is not there. So what can we do? So as I told you, the benefit of aspirin depends on your baseline risk. So you have to calculate your baseline risk. What's your baseline risk? And then comes the recommendation. Now our index patient, he was a male doctor of 45 years. So see what is the baseline risk. This is the Framingham risk score for calculation of baseline risk. He is 45-year-old, so male, 3 points. HDL was 45, 3 plus 1, 4. His systolic blood pressure was 140, 3 plus 1, 4 plus 1, 5. He is a non-smoker, so 0. His total cholesterol was 200, so add 7. So 7 plus 4, 11. And so this was our value, 11. So what is his risk? The risk is 8%. So his risk of having a coronary event in next 10 years is 8%. So this is a hypothetical situation. So what does the guideline say? So this is the guideline. If your risk is less than 10% of an event over next 10 years, then you did not take aspirin. Okay? If your risk is between 10 to 20%, then you have to be cautious. If you are prone for bleeding, gastrointestinal bleeding, if you have had bleeding in the past, if you have a bleeding history of ulcers, bleeding piles, then you need not take. But if the risk is more than 20%, then aspirin has to be taken. And you may stop it if there is bleeding. So this is clear cut. So who is the patient who should take? Not all patients with hypertension should take aspirin. Not all patients with diabetic should take aspirin. So that's the current recommendation about primary prevention with aspirin. Now what's the dose of aspirin? Is the increasing dose beneficial? Now these are the different trials which has dealt with different dose. And you will see the maximum benefit is with the dose of 75 to 150 milligram. So this dose is the best because if you increase the dose, chances of bleeding will be more. And if there is a less dose, then the benefit will be less. So this is an optimal dose between 75 to 150 milligram. So whichever the highest dose that you can tolerate between 70 to 150 milligram is the best dose for the person who is to take aspirin. Now another clinical situation, a 40-year-old symptomatic patient with severe rheumatic mitral regurgitation and normal LV function, he wants to undergo hernia surgery. It's a very common situation. Now what should one do? Now these are the answers which actually I wanted on a response system, a mitral valve repair and then hernia surgery, because mitral valve repair, as you know, carries that it is a valve is repaired, so no anticoagulation. So once valve is corrected, you can safely undergo surgery and no anticoagulation, so no risk of bleeding. So is this the proper answer? Go for mitral valve replacement and then hernia surgery, but patient should be shifted to heparin before hernia surgery as an anticoagulation for valve replacement. Proceed with hernia surgery, don't worry about mitral regurgitation. Or you do both simultaneously by 2 teams. What is likely answer? Anyone? Huh? Yes, go for hernia surgery. Now, how should a non-cardiac surgery be managed in a patient with cardiac surgery? Non-cardiac surgery can be performed with low risk in patients with AR-MR, even severe, provided LV function is preserved. Okay, so asymptomatic patient with, even if the MR is severe, if the LV function is normal and patient is asymptomatic, you can go ahead with a non-cardiac surgery safely. This is as against a stenotic lesion. If the patient has a severe mitral stenosis or a severe aortic stenosis, the guideline will differ. You may have to treat those first and go for this surgery. The risk of perioperative complication is highest in severe aortic stenosis because it is a fixed cardiac output state. So here you have to balance whether the surgery is more important, non-cardiac surgery, or this is more important. If the non-cardiac surgery is emergency, if it is obstructed hernia, then naturally you may have to go for it, not wait for this surgery to happen. But if it is an elective surgery, maybe you may have to treat a cardiac lesion first and then go for the hernia surgery. A 52-year-old diabetic with mildly positive stress test, he has walked for 7 minutes and he is to undergo elective intra-abdominal surgery. Proceed with laparotomy directly, start with beta blockers and statins before, perform coronary angiography and revascularization before surgery, start only aspirin prior. What is the likely answer? Anyone? Let's see, how do we deal with such situation? Any surgery, you have to go for a stepwise approach. Whether it is urgent surgery, what is the patient condition, whether patient is stable, unstable, what is the risk of the surgical procedure, what is the functional capacity of the patient, how much he can walk. Our patient has walked 8 minutes, that is 7 minutes, is a good functional capacity. What are the cardiac risk factors, whether it is hypertensive, diabetic, and what are the non-invasive tests. Now here our patient's stress test is positive. Now which are the low risk surgeries? You will see breast, dental, endocrine, gynec, reconstructive or neurological like TURP, endoscopic surgeries. These are very low risk, less than 1% risk. Our patient has an intra-abdominal surgery, so it is a moderate risk, intermediate risk patient, and high risk surgeries are the aortic and major vascular surgeries. So our patient fits in intermediate risk surgery. He has a good functional capacity and his stress test is positive. Now, does he have any cardiac risk factors? No, he doesn't have any cardiac risk factor. Only thing, his stress test is positive. He doesn't have MI, he doesn't have angina, doesn't have a diabetes, no renal failure, stroke or heart failure. Now, what are the guidelines? Should patient be treated with beta blockers, statins prior? Now, if you see, now these are the trials with bisoprolol, metoprolol and atenolol in perioperative patients who had proven ischemic heart disease at the positive stress test, angina or infarction. And you will see all the beta blockers, they are helpful. Whether it is the bisoprolol, whether it is the metoprolol or atenolol. So in perioperative phase, the beta blockers, they have a preventive role in preventing peri-ischemic events. So the recommendation is that beta blockers are recommended with ISD or myocardial ischemia according to preoperative stress test. So they are recommended. If the preoperative stress test is positive, then beta blockers are recommended. Beta blockers are not recommended in patients scheduled for low risk surgery without risk factors. Our patient was an intermediate surgery, so he will need beta blockers. Now about statins. Again, statins are useful as a preventive role in all non-cardiac surgery patients. So the recommendation of statin is, it is recommended that statin should be started in high risk surgery patients optimally between 30 days and 1 week before surgery, and they should have to be continued perioperatively. So, and same thing, the statin therapy, beta blocker therapy, and if patient has LV dysfunction, ACE inhibitors. Our patient doesn't have LV dysfunction. So for our patients, the patient, he has only moderate stress-induced ischemia, so we can proceed with surgery directly, but start him on beta blockers and statins prior. So start statins, start beta blockers, and then take him for surgery. No need of prior angiography and seeing coronary anatomy. A lady operated for mitral valve replacement with mechanical valve on warfarin 2.5 milligram and wants to plan pregnancy. Now this is a very common problem because you know there are two things. The prosthetic valve requires anticoagulation, and this anticoagulation warfarin is usually associated with warfarin embryopathy. It has a embryopathy, so that it has effects on the fetus, as well as warfarin can lead to increased bleeding, intraplacental bleeding. So you have a maternal risk, you have a fetal risk. So what should we do? Continue warfarin throughout, give heparin in first trimester, and towards term, in mid trimester give warfarin. Ideal to give heparin throughout pregnancy or give low molecular weight heparin. What is the answer? Give low molecular weight heparin. Anyone else? Okay. Now this is a very important slide which shows comparison of these options. Now you have to balance between warfarin embryopathy, spontaneous abortion, thromboembolic complications, and maternal death. If you give warfarin throughout, the embryopathy is 6.4%, spontaneous abortion 25%, thromboembolic complication around 4%, and maternal death around 1.8%. If you give heparin throughout, no embryopathy, but spontaneous abortion is roughly same. See thromboembolic complication, 33%. See maternal death, 15%, very high, not acceptable. This is both for low dose as well as high dose. If you give heparin first trimester and last trimester, and in between this thing, again, see thromboembolic combination, 9.2%, maternal rate 4.2, not acceptable. So heparin as well as this thing, heparin throughout as well as heparin in the first trimester, not indicated. Now, one option is we give vitamin K antagonist, that is warfarin throughout. Now, what about, sorry, that slide has been misplayed. What about low molecular heparin? The low molecular heparin, the problem about low molecular weight heparin, the trials which have been conducted with low molecular heparin is the incidence of thromboembolic complication is nearly as high as heparin. It can be brought down if you adjust the low molecular heparin dose according to anti-10A levels. Now, how many centers measure anti-10A levels? You have to maintain anti-10A levels between 0.7 and 1.2 units per ml, and you have to do this frequently every third or fourth day. Is it practically feasible? And that too, even if you do it, the results will be comparable with the oral anticoagulants. So, the current recommendation is the risk of embryopathy is dose related and is negligible if the dose is less than 5 milligram per cent. Our patient had a 2.5 milligram warfarin, so our patient should continue oral anticoagulants throughout, and she should conceive. No need of shifting to heparin, no need of shifting to low molecular heparin. That is the current recommendation. A 25-year-old lady has pregnancy-induced hypertension with blood pressure of 160 by 100. What should be done? Now, one thing one has to remember is all pregnancy patients, ACE inhibitors or angioreceptor receptor enzyme inhibitors, they are strictly contraindicated. So, no ARBs, angiotensin receptor blockers like telmisartan, olmesartan, losartan, they are strictly contraindicated, as well as enalapril. So the choice is between thiazides, calcium channel blockers, beta blockers, and of course, our traditional alpha methyl dopa. So if it is a severe hypertension, pregnancy-induced severe hypertension, these are the different drugs which you give. Nifedipine is the first drug that can be given orally, sublingually, brings down BP rapidly, very effective. Labetalol, also very effective, very safe in pregnancy, but not very potent. I have found, although it has been mentioned more often, I have not found to be very potent in reducing blood pressure. Hydralazine injectable is not available in India, diazoxide injectable is not available in India. So for us, only these two drugs, nifedipine and labetalol. So nifedipine, I will say should be the drug for pregnancy-induced severe hypertension or eclampsia. And for routine management of pregnancy-induced hypertension, you have alpha methyl dopa, then labetalol, then nifedipine. So these are the three drugs which have been found to be safe in pregnancy. If it is if the BP is very high, go to nifedipine. If BP is borderline, you can go give methyl dopa or labetalol. A 50-year-old gentleman on routine investigation was found to have lipid profile result like this: total cholesterol of 222, LDL of 150, triglycerides 150, HDL 42. How will you manage? Will you give him statins or will you not give him statins? Now till today, till 1 year ago, these were the guidelines which said if the cholesterol, LDL cholesterol, if it is less than 100, you do not treat it. If it is more than 130 and if you have risk factors, you give statins. And if it is more than 2 risk factors, then you have to be more aggressive. These were the earlier guidelines. But these guidelines have been totally changed in last 1 year. Now it is current guidelines which have been published in 2013 December, just 1.5 years ago. These have totally radically changed the lipid management. Now there are no targets. No target. Earlier you bring it down to 1 cholesterol, total cholesterol should be less than 200, LDL cholesterol should be less than 100, HDL should be more than 45. These were the guidelines. Now no targets. You select which patients to treat and bring down the lipids as much as possible. There are no specific targets. Second important thing is, earlier we were insisting on fasting lipid profile. Now no fasting lipid profile. Even a random lipid profile is good enough. Now which are the patients who benefit from statin treatment? That only you have to find out. Irrespective of their lipid levels. You need not check lipid levels in everyone. Some patients you give statins irrespective of whatever their lipid levels, even if you don't check the lipid levels. Now 4 major statin benefit groups. Individuals with clinical atherosclerotic cardiovascular disease, like patient who has angina, patient who has infarction, patient who has CVA, or patient who has peripheral vascular disease. So these patients with proven ischemic heart disease, angina, CVA, peripheral vascular disease or infarction, who have undergone CABG or angioplasty, they all should be on statins irrespective of their lipid levels. So if the patient comes, my lipid cholesterol is now less, 170. Should I stop statin? No, he continues statin irrespective of lipid levels. Second group who benefits is with the LDL of more than 190. If LDL is more than 190, you have to give statins. Third, patients with diabetic in the age group 40 to 75 and patients with LDL of 70 to 189. So if the LDL is between 70 to 189, patient is diabetic and in the age group of 40 to 75, he should give one statin. Even if he doesn't have atherosclerotic disease. So diabetic patients with a LDL of 70 to 189 should be on statins. And the fourth is patients without atherosclerotic disease, even if they don't have diabetes, if their 10-year risk is more than 7.5% of a coronary event, then you have to give them on statins. So if you see this, the cholesterol, statins initially came for cholesterol reduction. Now statin benefit is beyond cholesterol reduction. So they are not given for reducing cholesterol. They are being given for reducing coronary events, cardiac events. So you don't look at the cholesterol only for giving statins. And how do you calculate that risk of 7.5%? That is So these are the four. I told you about atherosclerotic dyskinesia, history of CAD, MI, and all this. This I have talked to you already. Then cholesterol more than 180, diabetic, that I told. Now this is a risk calculator that depends upon, these are the different demographics. What is your age, gender, race, hypertensive, diabetic, tobacco means smoking, total cholesterol, HDL cholesterol, systolic blood pressure. Depending on this, if you feed it to that calculator, CV calculator, that tells you your 10-year risk of having a coronary event. If it is more than 7.5%, your patient should be on statins. So that's it. So no targets. If you fit into that group, you take statins. If you don't take statins. So that's it. Now another practical question. A 24-year-old doctor lady, she has a small VHD and she wants to conceive. What should you do? Should undergo VHD surgery first and then pregnancy? No pregnancy, because in mothers with VHD, baby is more likely to have VHD. Can conceive as VHD small and chance of CHD in baby is very low. Or can conceive as although baby develops VHD, it can be easily treated. What's it? C. Now, the 2-3 things we have to discuss here. One is, who are the patients of congenital heart disease who are high risk pregnancy? Second, what is the transmission of a congenital heart disease to the offspring? These are the 2 important things which we have to discuss in this. Now, pre-existing conditions which may confer low maternal risk. All left to right shunts, AHD, VHD, PDA, they are low risk, so they can safely conceive. Or regurgitant lesions, AR, MR, they can safely conceive. If left ventricular outflow obstruction is not severe, they can safely conceive, like aortic stenosis if it is not severe. And RV outflow, pulmonary stenosis, if it is not severe. So all these patients can safely conceive, all these patients. Now, which are the conditions with a high maternal risk? Severe pulmonary hypertension because of any cause, like primary pulmonary hypertension, AHD with pulmonary hypertension, mitral stenosis with pulmonary hypertension, severe pulmonary hypertension of any cause. If it is a severe LV inflow or outflow obstruction, severe mitral stenosis, severe aortic stenosis, hypertrophic obstructive cardiomyopathy, then this is a very high risk situation. Marfans, very high risk. Coarctation, very high risk. And of course, prosthetic valves, because they are on anticoagulants, high risk. All severe cyanotic heart disease, like tetralogy of Fallot, tricuspid atresia, they are high risk pregnancies. So these are the maternal condition with high risk. Now, if the patient is in class 3, class 4, that means is significantly dyspneic, significantly cyanotic, then that's a high risk pregnancy. Now, what is the chance of transmission of congenital heart disease to offspring? See, tetralogy. What is the chance of transmission? If the mother has tetralogy, the baby of having tetralogy is only 2.5%. If the father has tetralogy, baby having is only 1.5%. The only condition where there is a high risk of transmission is LV outflow obstruction. That is aortic stenosis, coarctation of aorta, and hypertrophic obstructive cardiomyopathy. These are the only high risk condition where if the mother has this condition, then the offspring having likely to have this condition is more, but that too is not very high. So no congenital heart disease is transmitted to the offspring, whether the mother has or the father has. So on that account, you need not avoid pregnancy. Next, a 24-year-old lady with tight mitral stenosis and pulmonary hypertension is pregnant and wants to continue pregnancy. How will you manage? Send for balloon valvotomy in first trimester, send for BMV in second trimester, send for BMV in third trimester, send for BMV only if symptoms develop. Yes. Now, why second trimester? In first trimester, BMV involves radiation. You are doing in a cath lab. So, there is radiation. So, you don't want to expose fetus to the radiation risk. That's why you avoid in first trimester. You would have liked to do in first trimester, but you can't do it because there is radiation involved. Third trimester, the patient, because you know around 28 weeks there is maximum blood volume increases and the patient might go into heart failure. If the patient goes into heart failure, then patient may not be able to lie down flat. For BMV, the patient has to lie down flat. Should not be orthopnic. because then you may have to give GA, put on ventilator, and everything increases risk. So the second trimester, in an asymptomatic patient, the second trimester is the best period for BMV if the patient is asymptomatic and if the patient has a severe mitral stenosis and pulmonary hypertension. The patient has a moderate pulmonary mitral stenosis, no pulmonary hypertension, you need not do anything. Severe mitral stenosis and pulmonary hypertension, they have to be treated. And if the patient are already, ideally they should be treated before pregnancy. But here you have come to know after the patient has conceived. So that's it. So percutaneous mitral commissure should be considered in pregnant patients who have severe symptoms or pulmonary artery pressure more than 50 due to mitral stenosis despite medical therapy. So that's the indication. A 65-year-old diabetic gentleman comes with typical retrocernal chest pain of 4 hours duration. His ECG shows acute entry infarction. Now, how will you manage? 4 hours duration, how will you manage? You are going to do a primary angioplasty or a thrombolysis. Now, this is a thing that one has to know because still in many centers, the ideal treatment is not given. One has to know time is very essence in treating acute myocardial infarction. Time is very important because here you will say the time of onset. The more time you lose from 0 to 1 hours, 0 to 1 hours, 2 to 3 hours, 4 to 6 hours, 7 to, the more time you lose, then the mortality increases. So you save only 16 lives after 7 hours. But if you are able to treat in first hour, you save 35 lives per 1,000 patients treated. So faster you treat infarction, faster you open the artery, the more lives you save. Similarly, the more myocardium damage occurs, the time you lose. Time is money and muscle is time. So remember, so if you lose time, you lose muscle. Then you lose myocardium and you are likely to have a patient who is alive but in heart failure. So you have to treat this very early. Now this is a slide which shows comparison of angioplasty versus thrombolysis in acute myocardial infarction, and clear cut primary angioplasty is definitely better than thrombolysis. So a patient who can be treated by primary angioplasty, he is affordable, should be treated by primary angioplasty in any situation if the facilities are available and if the patient is affording. If this has been shown in acute phase, and if you see this benefit lasts over the time, over the days, after 200 days also, the benefit lasts. There is a significant gap between the primary angioplasty and thrombolytic survival patients. Importance is how not only doing primary angioplasty, but how early you do it. So this is what is called as the door to balloon time. From the patient who comes to your casualty and you take him to the cath lab and open the balloon, you balloon dilate it. How much is the time you lose? If you lose that time, if the door to balloon time, if it is more, then the advantage is lost. So if your door to balloon time is more than 90 minutes, that is more than 1.5 hours, if you feel that, why I am saying, a patient comes in the midnight at 2 o'clock, and if you get the cath lab functional, if somewhere a city like Mumbai, if staff is going to come from 2 outstation, cardiologist is going to come from his home, which is going to take 2 hours, and the door to balloon time is definitely going to be more than 2 hours, then no point waiting for that patient to go primary angioplasty. Here you should thrombolize him. Okay, so door to balloon time more than, if it is going to be more than 90 minutes, then thrombolize him. So this is delay time. If the door to balloon time increases, whether it is for thrombolysis or whether it is for angioplasty, if the time you take for opening the artery, then you are going to lose the patient or lose the myocardium. So if the expected door to balloon time is less than 90 minutes, then go for angioplasty. If the expected door to balloon time is more than 90 minutes, go for thrombolysis. So that's it. Now this is showing the importance of a primary angioplasty. This is a 36-year-old gentleman who had come to me, a 36-year-old school teacher, came to me with acute myocardial infarction, BP not recordable, recurrent ventricular tachycardia, had twice cardiac arrest, resuscitated in casualty, no relatives with him, and he came. Now, I didn't know what to do, but considering he was just young, 36, I thought just take him to cath lab. I didn't know whether he is affording, not affording, he will survive, not survive. And this is when I took him for angio. You will see this is what is called as the left main coronary artery. Now, left main coronary artery is 100% occluded. Now, this is a miracle. A left main coronary artery which supplies blood to nearly 80 to 90% of the heart blood flow is supplied by left main coronary artery. They don't reach hospital. They don't reach next room. They don't reach next room. There is a nearly on the spot death if the left main coronary artery is 100% occluded. He reached hospital. In fact, he reached cath lab. And I could get his puncture femoral, which was difficult because BP was not recordable. And fortunately, now this is a balloon. This is a thrombus aspiration catheter. Some trickle of flow you will see in the coronary artery. This is a stent implantation. You will see this is a stent implantation and successfully stent implanted. And this is a good result. I opened the artery, but he continued to remain in shock for next 25 days in ICU. But it is a miracle to say, now this is nearly 6 years on. This patient is alive, only on aspirin and statins, and he has walked home. This is one of the miracles of the science, and especially miracles of primary angioplasty. So any patients of acute myocardial infarction, you have to give him benefit of primary angioplasty. This is the message of this slide. Thank you.